and minimally invasive urological surgery at Robert Wood Johnson Barnabas Health, Jersey City Medical Center. He is a clinical professor of urology at Rutgers University, a clinical instructor at Mount Sinai School of Medicine, and a speaker lecturer at national and international conferences. So we'll go ahead and hand it over to you, Dr. Larish.
Well, thank you so much for that introduction. When I hear introductions like that, I almost ask, who are we talking about? Is that me? Is that possible? So that's really nice. Thank you so much. I want to welcome everybody, and I appreciate the opportunity to speak tonight. And hopefully, we can make some difference in somebody's life tonight. If not for somebody tuning in, maybe for a loved one who's of someone who's tuning in, or for a friend or a family member. And knowledge is power, and that's the goal for tonight, is to really empower everybody who's tuning in and their loved ones about what they can think about and understand a little bit about their bodies and their journey through fertility and the quest for having a family when they're affected by this disease. So I think maybe we should start with a little bit about statistics of endometriosis, because I think it will put into perspective a lot of the questions that people have, and maybe will get people's gears turning in thinking about a loved one who maybe has been faced with this and just doesn't have a diagnosis yet, and might empower some people to make some good choices and be armed with knowledge. So if we think about endometriosis is a disease that affects 1 in 10 historically women of childbearing age. And in more recent times, that number is actually likely closer to 1 in 9. And that's a pretty big number of people affected by this disease. If we then take a look at the subset of people with endometriosis who have fertility issues, it's a big number. It's a big number. So if we look at people who are undergoing IVF treatment, for example, 10% of all IVF treatment is in patients who have a diagnosis of endometriosis. If we then look at people who've had a failed IVF treatment, meaning they've gone through the medications and the time and the expense and the emotional expense, not just the financial expense of going through a fertility cycle, 1 in 10 who fail are because of an underlying unknown diagnosis of endometriosis. If we look at the percent of patients who have a failed embryo transfer, meaning they're able to harvest an egg, they're able to harvest sperm, they're able to put them together under the microscope and make an embryo, and fail at transfer of that embryo into the uterus, again, it's 1 in 10. So this is a very, very big number of people in the United States and in the world entirely. And there are a number of reasons for this. So endometriosis, in very broad terms, is a disease that affects the whole body. It's not just a reproductive disease. And that's important to understand, because many of the effects, including the effect of infertility, has to be viewed as a whole body, whole pelvis sort of disease. It can't just be viewed through the reproductive organs. Endometriosis is when the inner or tissues that are similar to or resembling the inner lining of the uterus that sheds every month during the period are found outside of the uterine cavity, whether that's in the uterine wall itself of the muscular layer of the uterus that's called adenomyosis, or on the pelvic organs, the ovaries, the bladder, the ureters, the fallopian tubes, the nerves, the rectum, or even outside of the pelvis, places like the appendix or the diaphragm, the muscle of respiration. So this is a disease that it can affect really the entire body. The hallmarks, and the reason why this is important to understand is because in the same way that the uterine lining the normal uterine lining sheds every month during the period, during the menstrual cycle, those cells that are similar to or resemble that cellular structure but are found outside of the uterus respond in the same way. And so you end up getting a whole body period. And I think that's a really important concept to understand because a period really should be limited to the inner lining of the uterus shedding. And when the entire body is affected, there are consequences to that. Those cells that resemble the uterine lining but are found outside of the uterus are similar to the lining of the uterus in that they respond to hormones. And so they will contract and grow and bleed in the same way that the uterine lining will do the same thing during the menstrual cycle. The consequences of that is that we have an environment in the pelvis that becomes really inhospitable to carrying a child. And that's from the beginning, from the first moment. So if we think about the steps that are required during the natural progression towards a pregnancy, you have to, first of all, ovulate. And if you have an inflammatory rind, almost like an orange peel that's coating the ovary and preventing ovulation, or misdirecting the egg that ovulates away from the fallopian tube, it's going to be very, very difficult to get pregnant. If we then think about the inflammation that results as a result of the endometriosis being present in the pelvis, that inflammatory environment is very, very deleterious or negative towards good egg quality. It's deleterious towards normal ovulation. It's deleterious to a number of reasons. If, let's say, that we are lucky enough to ovulate and an egg is released, that egg then needs to be taken up by the fallopian tube. But if the fallopian tube is blocked because of endometriosis implantation on the fallopian tube, or if the fimbria, the little hair-like structures at the tip of the fallopian tube are stuck together because of the inflammation that ensues within the pelvis as a result of the endometriosis, it's very difficult for the fallopian tube to collect the egg. If you're lucky enough to ovulate and you're lucky enough for the fallopian tube to collect the egg and direct it towards the uterine cavity, a healthy egg, which we already said is a challenge given the inflammation that ensues as a result of endometriosis. If you then have adenomyosis in the uterine wall, it's very difficult for implantation of the fertilized egg that occurs within the uterus to implant into the uterine wall. And so there are many, many challenges here, some of them immunological. We know that patients who have endometriosis have a host of autoimmune diseases, and that's likely a result of the very inflammatory environment that the patient has within their body as a consequence of the endometriosis. Those autoimmune diseases can cause inflammation within blood vessels. They can cause early miscarriages. They can cause failure to implant an embryo, and so it becomes a real challenge. Putting all of that aside, let's say that we're lucky enough to ovulate. We're lucky enough to collect the egg with the fallopian tube. We're lucky enough to have fertilization of a normal egg. We're lucky enough to create an embryo, and we're lucky enough to implant into the uterus. We have to remember that in order to get there, one of the ways to do that naturally without the aid or assistance of reproductive technologies is through sex. And that is a really big challenge for many endometriosis patients in the form of pain and in the form of not just pain during, so pain during sex is one thing, but, and I'm not minimizing that at all. But if you are in constant pain, or if you're in pain 3 weeks out of 4 weeks in the month, there is a price to be paid from that psychologically. I can't even begin to imagine being in pain 3 out of 4 weeks a year, a month, or 4 out of 4 weeks a month, and then wanting to be intimate with someone. It's really, really challenging. And so these are all really problematic in the quest for having a family. And I think one of the one of the um, one of the cruel things about life is that we, in our younger years, in our teens and our 20s, we do everything that we can to prevent pregnancy. We're scared to death by our parents, by sex education classes, by television shows. We're scared to death about everything about not getting pregnant, and then we meet the right person. We decide that we want to have a family, and having a child is not always an easy task. Sometimes it's a real journey to get there, and sometimes it's an impossible journey. And so I think there's a real push and pull between uh, where we start in trying to prevent pregnancy in the early part of our life, and then wanting to have pregnancy and thinking that you just flip the switch on and it's going to happen. It doesn't always work that way. And so I think that I completely empathize and sympathize with anybody who's going through a fertility quest is how I like to call it, not an infertility quest, but a fertility quest for any reason, but particularly in the endometriosis population because of the associated pain, stigmatization, poor care, ignorance of many doctors, turning a blind eye, gaslighting. You name it, this disease has it. And so I just want to first say to everybody who's in the audience and anybody who's tuning in, there are people who hear you. There are people who can treat you. Um, just because your quest is difficult doesn't mean it's impossible necessarily, and you just need to have the right team around you. So that's my introduction. I don't know. Hit me with some questions. I got you.
Okay, wonderful. I'll start the ball rolling while people put their questions in the chat box on Facebook Live. Also send us all your questions. And I'll start with the first question. What's the most common presentation or factor that you find affecting fertility in endometriosis patients?
So I think that every story is a little different,
Hmm.
and I think it's important not to generalize, but there are certain hallmarks. And so I guess it's a two-part question. The first part of the question is, how do I what would make a doctor think, hey, maybe this patient has endometriosis as part of their story in the background of why they're having difficulty in having a baby.
Hmm.
And um, it's not all that difficult to figure that out, frankly. If you're in our practice, we ask, do you have pain with sex, particularly with deep penetrative sex? Um, have you ever missed school or work because of your menses? And do you have associated bladder and or bowel um, comorbidities, meaning urgency, frequency, waking up at night, incomplete emptying, running to the bathroom, incontinence? If you've been diagnosed with IBS, emphasis on the BS of IBS. Those are all things that should clue us into the idea that there may be a comorbid condition that's sort of driving the cart here. Um, what we often see is patients who have skipped that step of the diagnosis and have tried to conceive, and rightfully so have sought out medical care, and they've seen a reproductive endocrinologist or an IVF clinic, and the IVF clinic or reproductive endocrinologist immediately suggests, oh, you need IVF, or you need an IUI, an intrauterine insemination, or an in vitro fertilization. And the challenge here is that many of the reproductive endocrinologists and IVF doctors believe that IVF can overcome many of the challenges that endometriosis presents. And I just don't believe that to be the case. I think that, the average number of cycles to get pregnant in the United States is something like, it's over three cycles in IVF at a cost, a significant financial burden and a significant emotional burden, and a significant time burden, where if the endometriosis was treated, maybe that number would be significantly less, meaning the number of cycles would be less, and therefore the amount of time, amount of money, amount of heartache that the bill is paid in all of those arenas by patients who are pursuing their fertility quest. And so, I think you have to take a good history. And if you hear any of the stigmata, meaning all of those things that we talked about, the pain with sex, the missing of school or work, the associated bladder and bowel conditions, that should raise a big red flag. And the second thing that raises a big red flag is people who've tried IVF once, twice, 3 times, 4 times. We've seen patients who've gone through 7, 8, and 9 cycles of IVF with no success. And that should raise a big red flag to whoever is doing those cycles to say, wait a minute, maybe there's something in the background here that's driving our failure to succeed. And so I think that's the long-winded answer to your question.
Okay, wonderful. Thank you so much. Our first question isn't infertility related. I know what my answer is for this question. But can you advise anything about Lupron following a hysterectomy, a lap or hysteroscopy?
Can I advise anything about
Lupron
for
use.
the treatment? Yes. So you're getting me all riled up. All right.
I
So
know.
here's the deal, right? So Lupron, which is used by some doctors to stop the hormonal access from allowing for a period to happen, originated as a prostate cancer chemotherapy drug. All right, I want everybody to think about that for a second. So this is a drug that was used for years by urologists to treat metastatic prostate cancer. And the reason they did that is because there are a lot of parallels that can be drawn between prostate cancer and endometriosis. Prostate cancer is abnormal cells found outside of the prostate, found elsewhere, metastatic prostate cancer, that is. And if the prostate cancer or derangement of the cells is the fire, the gasoline that's poured on the fire is hormones, is testosterone. And so Lupron in men, takes away testosterone, and that's how they control metastatic prostate cancer. In a similar way, endometriosis if endometriosis is the fire found outside of the uterus, the gasoline that's poured on the fire is estrogen. And so Lupron takes away the estrogen. It stops the brain from sending the signals to the ovaries to produce estrogen. It's highly problematic because there is data in the prostate cancer literature, and in fact, it is a guideline in the prostate cancer literature that you can give somebody Lupron for a short period of time, usually 6 months, and then withdraw the Lupron and still have the testosterone remain at 0, meaning we have castrated somebody with 6 months of the Lupron. Now, in an 85-year-old man who has metastatic prostate cancer, the risk-benefit that's weighed there, where we're thinking about what are the risks and the benefits of doing that to someone, the benefits outweigh the risks in an 85-year-old male. In a 25-year-old woman with reproductive aspirations and with a whole life of bone mineral density that they have to support, that's reliant upon estrogen, dementia risk that is reliant upon having estrogen in the body. That is highly problematic because giving somebody a short course of Lupron may cause irreversible derangements in the hormonal axis. And that is incredibly problematic. That's number one. Not to mention the fact that just because you extinguish a flame, the resultant fibrosis that occurs and scarring is not treated. And so we see many times patients who are put on Lupron, they get some relief, usually temporary, and then this disease comes roaring back, even though they're still on Lupron. So it's very problematic. I think Lupron is really a drug that should be reserved as a last-ditch effort in the treatment of endometriosis. A last-ditch effort, meaning somebody who is so debilitated, and I mean cardiovascularly debilitated, that they cannot undergo the surgery that they need to treat the endometriosis. That's the only time that I think Lupron actually plays a role in the treatment of endometriosis. Now, that's not to be confused with the Lupron that's used as a trigger to cause ovulation. So we have to separate Lupron being used as a treatment dose at a very high dose. And when I say Lupron, I mean all of the hormonally mediated drugs. So that's Lupron or Alyssa, Degaralex, Myfembry. There's a million drugs. They all end up at the same endpoint, which is to stop estrogen. I think that there's a very big difference between using those drugs to control a disease, or to attempt to control a disease, because I don't think it actually controls it, and the mini dose that's used to trigger ovulation. I think we should just make sure that people understand that it is a reasonable and used and common practice to use Lupron to cause ovulation, but that's not the same Lupron that we're talking about in terms of treating endometriosis.
Okay, thank you. Thank you, Alexis, for that question. Ivy wants to know, having endometriosis, adenomyosis, and PCOS, is any one of them the biggest cause of infertility?
No, I don't think, chronic pain and fertility need to be, as human beings like to think of things as cause and effect. We like to think of things linearly, meaning if you have this problem, this is the solution, and if this is the solution, it solves this problem. Chronic pain and fertility needs to be thought of more like several balls of yarn that have all been jumbled up and mixed together. And you cannot pull on a single strand of yarn and think that you're going to undo the knot that ensues. You have to pull on all of the ends at the same time to undo the knot. And so what I'm saying is the endometriosis needs to be treated. The adenomyosis needs to be controlled. The PCOS needs to be optimized. There's no one lever that one can pull on to fix a very complex problem. I think that that's a complicated combination of problems that each require their own, if not solution, at least their own attention in order to try to optimize, in order to get to the bottom line goal, which is, in this case, fertility for this discussion.
Wonderful. Ivy has a second question. She's heard that through a Nook endo specialist, endometriosis can cause the amount of eggs a woman has to diminish at a faster rate. Do you know at what rate?
I don't know the data on that, but I can tell you that that makes perfect sense to me. Just the mere presence of endometriosis, as I mentioned earlier, causes a lot of inflammation in the pelvis. It causes a derangement in the hormonal levels that exist, both in the body as a whole, but also locally at the level of the ovary. And so it's no surprise that endometriosis has deleterious effects on egg counts and, more importantly, on egg quality. I think since we're talking about, um, since the focus of this discussion is fertility, I want to remind everybody that um, it really takes one good egg and one good sperm to make a good baby, right? And so it's not, to me, it's not so much about, oh, my egg numbers decreased and will surgery decrease them? It's about optimizing the quality of what we have to work with. And this is a raging debate between REIs and endometriosis excisional specialists, because the IVF doctors say, let's get as many eggs while we can. Let's get them. Let's stimulate. We may make the endometriosis worse, but at least we'll get the eggs. And the excision specialists say, wait a minute, let's address all of the inflammation and all of the derangement in order for the quality of the eggs that we have to be as best as they can be. And I don't know that one is right or one is wrong. I know which one I believe in, being an excision specialist. But that debate is raging. I don't think that there's a clear consensus on that. And that's one of the problems with endometriosis and adenomyosis as well, is that consensus is not the name of the game here. But one has to wonder, what are the forces at play that push and pull in the different schools of thought? And many of them really have nothing to do with patient care. They have to do with financial considerations by large private equity-backed IVF clinics. They have to do with what insurance does and doesn't cover. It has to do with women's health in general. I think there are mega forces at play here, which cloud the conversation in a way that it's a little difficult to get to the truth, so to speak. But I can tell you from my perspective, I believe that it's not so much a question of quality, of quantity. It's a question of quality. And you may harvest, 40 eggs that are poor quality, but what have you actually gained from that? Not much. As opposed to maybe you've harvested 15, but they're all great. And each one of them has the potential of creating a baby. And so I think that's really my answer to that question.
Okay, great. The next one, Carrie says she's waiting for a full hysterectomy, but the surgery got canceled after being diagnosed with endo of the bowel. She's been having frequent bowel movements and a lot of pain, diarrhea, and feeling flamed up inside. Is this normal? All of this is new to her.
Well, I would say, first of all, thank God they canceled the surgery, because a hysterectomy is not the treatment here. Many gynecologists, general gynecologists, do what they can do. Are you familiar with the story of the three blind people in a room with an elephant? One is an electrician, one is a carpenter, and one is a hairdresser. And they're all blind. And they put their hands on the elephant in the room. And the electrician holds the elephant's tail and he says, "Oh, this is an electrical cord." And the carpenter touches the elephant's leg and says, "Ooh, this is a great piece of wood." And the hairdresser touches the little hair on top of the elephant's head and says, "Oh, this is a mannequin that we're going to practice giving a haircut to." Just because your worldview is through the lens of an electrician or a carpenter or a hairdresser doesn't mean that that's the right thing to do. So, for example, the patient's question, I'm sorry, what was her name? I don't mean to refer to her as the patient, because she's not my patient.
Carrie.
So Carrie's question was, I had my hysterectomy canceled because they found endometriosis on my bowel. I feel I have all of the complaints of endometriosis on the bowel. This is all new. So the question is, as I said, thank God they canceled the surgery, because hysterectomy would do nothing to help with your bowel symptoms. And that's oftentimes a tragic patient that we see, is someone who's been robbed of their ability um, to carry a child in their uterus because they've removed the uterus. And to add insult to injury, haven't actually dealt with the actual problem, which is the endometriosis implants on the bowel. Uh, is it normal? No, it's not normal. But this is what it is. You have endometriosis on the bowel wall that needs to be addressed surgically. There's no other way to really treat that. There are many, many ways to treat endometriosis on the bowel, but they're all surgical. And if you go to a place that knows what they're doing and does it at a high volume, you'll have an excellent result, and you'll be able to keep your uterus. I don't think removing uterus is the right choice here. But I completely sympathize and empathize with what you're going through. Like I said, many patients are diagnosed with IBS for years. Constipation, diarrhea, shooting pains, in the rectum when they poo, pain going down the legs when they poop, all sorts of things that you say, well, it's so obvious what it is. And yet they're told they have IBS, and then they get their uterus removed and their pain continues. So hysterectomy is not, I repeat, not the solution for endometriosis, particularly when it's on the bowel.
Wonderful. Cassie asks, can one get pregnant naturally after having excision surgery, or does it depend on how bad the endometriosis is?
So the answer is yes. In fact, we just saw somebody who got pregnant 3 months after their excision, after a 7-year battle with fertility. Got pregnant naturally. They had an IVF appointment lined up for the week later, but she had a pregnancy test at home. She canceled it. So, and she had severe endometriosis. So, yeah, I think that if you treat the disease and you do good, complete excision of the disease, wherever it may lie, you have now optimized the patient to be perfectly ready for potentially a completely natural pregnancy. The challenge is that patients are so drawn out, but there is a biological clock, right? We do have to accept that there is an optimal age at which the number of eggs that are available and the quality of eggs is the greatest, and it dwindles with time. And the tragedy is that if it takes 12 years to get a diagnosis, if you start menstruating at 12 and it takes 12 years to get a diagnosis, and then you're gaslit, fed misinformation, treated with the wrong surgery, and all of a sudden you're 35 by the time it's figured out, our window for a natural pregnancy is small in those situations. So the key is an early diagnosis and then the right intervention. Early intervention and the right diagnosis is the key. But yes, there is certainly possibility of getting pregnant naturally after surgery. And in fact, it happens really quickly after.
So that kind of goes right into the next question. Bethany wants to know, how soon after excision should one begin to try?
So Bethany, I appreciate the question, and I think it completely depends on what was done during surgery. I think that more complicated surgery with say a partial vaginectomy, if we have to shave disease off of the vagina, some people will tell you to wait 2 months. But I think 2 or 3 months is sort of the longest time I would tell somebody to wait. A lot of our patients, we tell them as soon as you're ready, as soon as you can tolerate your partner, you go for it. And if that means 6 weeks, so be it. If that means 4 weeks, so be it. If it means 3 months, so be it. But that's usually the time frame. It's really short thereafter.
So this is our last question for now, and then we're going to go to Claudia. Piggybacking off of this, and this one's a little bit of a loaded question. If they don't excise all of the endo, are your chances still increased for pregnancy without medication treatment after?
So medication treatment after really plays no role. I think that if you're going to put your life in somebody's hands, and make no mistake, that's exactly what surgery means. You're putting your life in somebody's hands. and you're trusting them to do the job. And the job here means to clean out the endometriosis anywhere and everywhere. The goal of surgery should be complete removal of disease wherever it may be. We all too often see patients who, just last week, we saw somebody who had surgery for endometriosis 2 months prior. She was young, in her 20s, and they had done an excision, but they removed two little ditzels of an area the size of a dime and left horrific, deeply infiltrating stage 4 endometriosis on the rectum. There's no way that that pelvis is going to be hospitable to getting pregnant or carrying that pregnancy if you don't really clean it out. So, just to give you a little bit of insight, and then Claudia with the amazing glasses is going to take over because I need to drink a sip from my soda. If you look at the doctors who are treating endometriosis in the United States, you have to think of it as a pyramid, with the base of the pyramid being the largest number of providers, and then fewer and fewer providers as you go up the ladder towards the top of the pyramid. At the base of the pyramid are the general gynecologists and obstetricians, many of whom their entire training of 4 years to become an obstetrician and gynecologist consists of 2 years of obstetrics. That means delivering babies and C-sections and, breech delivery, all sorts of very, very important, complicated situations that have nothing to do with endometriosis or being in the operating room, right? So that's 2 years out of the 4. So down now to 2 years of training, surgical training. And of those 2 years of surgical training, 1 year is spent doing subspecialty work, following the IVF doctors in the clinic, following the high-risk pregnancy doctors in the high-risk pregnancy clinic, following any sort of family planning, whatever it is, you name it, but it's not in the operating room. So now we're down to 1 year. And in that 1 year, they're expected to learn how to treat a disease that affects the entire body surgically. It's preposterous. That's the bottom rung. That is the largest number of providers are in that category. And so when they're confronted with a patient who has all of the very obvious signs of endometriosis, the ones that have insight into their training will say, I am not capable of treating this person for what they have, and therefore I may just turn an eye and say, maybe it's not, maybe it's something else, maybe it's IBS, maybe it's fibromyalgia, maybe it's this, maybe it's that. And they throw a million diagnoses at the patient in order to avoid having to do the right thing, which is the surgery. Or if they are slightly more insightful and they say, okay, this is endometriosis, let's put them on Lupron. Let's put them on Orlissa. Let's put them on Myfembree. So that's the most common sort of and largest number of providers in the United States. One rung above that are doctors who have decided to dedicate their practice to the surgical side of things, but they're doing hysterectomies, they're doing fibroids, they're taking care of a million and one diagnoses, and they'll see the occasional endometriosis, they'll see a case of it every 3 weeks. And they'll see the endometriosis and they'll say, okay, yes, I've diagnosed endometriosis. I'm just going to burn it because I'm not comfortable doing the surgery. And so they'll take a little cautery and they'll zap the area and they'll burn it. The problem is that endometriosis is like an iceberg. What you see on the surface is only 1/3 of the disease. The other 2/3 are below the surface. And that burn, that zapping, does not actually address the 2/3 that are under the surface. That's a smaller proportion of the doctors that are out there, but it's still a very large portion of the obstetrics and gynecologists that exist in the United States. One rung above that are the doctors who say, I understand, I've dedicated my life to surgery. I see a fair number of endometriosis patients. I see 3 a week. I see 10 a week surgically. And I don't believe that zapping the disease works. I'm going to cut it out. But I am, after all, an obstetrics and gynecologist with 1 year of training. I don't feel comfortable cutting out disease from bowel. I don't feel comfortable cutting out disease that's on the ureter or on the bladder. I don't really feel comfortable taking out an endometrioma because I fear that I may end up removing the ovary. And so I may just drain an endometrioma or a cyst in the ovary, but I'll leave it behind. Uh, Again, a smaller number of doctors, but they're doing the best that they can. They're not, in their minds, they're not doing the wrong thing. It's just they don't have the skill set that's necessary for a very complicated surgical disease. And then the level above that are doctors who have dedicated their life not just to gynecology, not just to endometriosis within gynecology, but they've also dedicated their life to excision. And those are the doctors that believe that removing the endometriosis is the right thing to do. It's the only way to treat this disease surgically. And so they'll go whole hog and really excise the disease. Unfortunately, in the United States, I don't believe that the number of doctors who are doing that is more than a couple of hundred for a disease that affects 1 in 9 women. I think that's really problematic, really problematic. So again, a long-winded answer, but that's my answer.
Thank you so much, Dr. Larish. We're going to continue with more questions later, but now it's time for Claudia, our wonderful, lovely Claudia. Claudia Campbell is a native Jamaican who works as an actuary in the health insurance sector. She is based in Connecticut, where she lives with her husband, Andrew, and her twin daughters, Eliana and Nia. After over 20 years of debilitating pain and then unexplained infertility, she was diagnosed with stage 4 endometriosis and was left with more questions than answers. 5 failed surgeries later led her to self-directed research, consulting with advocates on Facebook and support groups. As a result, she had her most recent surgery in 2019 with an excision specialist and followed up with pelvic floor therapy. It was the first time she had lived without pain. Claudia believes in the power of community, and when she's not running behind her daughters, she now spends some of her free time advocating and being a listening ear to those that are currently walking through endometriosis, infertility, or grief. She believes that no one should ever have to walk alone. Thank you, Claudia, for joining us. Oh, you're muted. There you
Hello,
go.
hello. How are you?
Hello.
All right.
And so please tell us more about your infertility journey in particular. What was your first experience with the term endometriosis? What were the, well, with the term infertility, what were the steps the doctors initially took? And take us from there.
Sure. As Dr. Larish was talking, and thank you so much, Dr. Larish, for everything you shared. It was so on point. I actually got a bit emotional listening to you talk about endometriosis, speak about its impact on infertility, because what you were saying was so much aligned with me and my story, our story as a family. For us, we were struggling with infertility for many years. It was initially 1 year of actively trying to conceive, where before we actually sought out the assistance of a reproductive endocrinologist. But before that, it wasn't that we weren't trying to not get pregnant, right? I was diagnosed, I was on birth control at a very young age, from 13 years old, to manage pain, right? Pain that was very debilitating, pain that had me home from school for days at a time. Later on, after I started working, I would miss work days at a time. And then after we got married, while I came off birth control, I wasn't trying to get pregnant necessarily, but it also never happened. And so once we did start really actively trying to build our family, to grow our family, a year in, we realized that we weren't seeing any results. I was getting, negative pregnancy test after negative pregnancy test, and we decided to go to see an RE. Once there, I was diagnosed with unexplained infertility. And for me, I first heard about endometriosis after I had already had 2 failed IUI cycles. So I had 2 IUI cycles that failed. I did do an exploratory surgery that led to the diagnosis of the stage 4 endometriosis. At the time, I was told by my RE, it's stage 4, but I did remove what I could. The rest cannot be removed, and so you're going to need IVF. And so after that, um, over the course of several years, I actually had an additional 4 surgeries that later on I learned that they were actually ablations. At the time, they just kept saying, we're going in to remove the endo that's there as a part of your fertility treatment, your fertility journey. Every single time we would try to make another attempt at IVF, they would go in and say, hey, the endometriosis is back, and so we need to go in and remove it again. Unbeknownst to me at the time, I was just going through ablation surgery every single time. My pain would be back within months. And within 10 months, the endometriosis would be quote unquote back. And I was literally having surgeries every 10 to 12 months. I say that it was sprinkled throughout my IVF journey because the reality is that in addition to the 2 IUI cycles that I did 7 rounds of IVF. So I was literally the poster child for, as you were speaking about the multiple IVF cycles. I did not actually get a positive pregnancy result until my 5th IVF cycle. And so whether it was due to egg quality that resulted in embryo quality that was poor, or just it not implanting, because I was told I had a toxic womb. I did also have adenomyosis as well. And so for me, I actually did not get a positive pregnancy test until my 5th IVF cycle, and that did end in a miscarriage. On my 6th IVF cycle, I was fortunate to be pregnant again. I was pregnant with triplet boys. And at almost 24 weeks, I gave birth to all 3 of them, and they passed away shortly after birth. And so I lost 3 sons. We had about 30 minutes with each of them. And so I talk about it now. It's hard to think about it ever so often. You kind of mix the joy that I have right now with my daughters and the grief with my sons. Every now and again, they all blur, and I kind of hold them both in my hands in each and every single day. On my 7th IVF cycle, that was kind of when I didn't even want to go again. My husband kind of encouraged me. He said one more time. I thought he was kind of crazy. But we decided to do one last round of IVF. And on my 7th round of IVF, we were blessed with 2 girls who are now 9. And they are, they drive us crazy, and they're the joy of our lives all at the same time. And so it's been a roller coaster of a ride. I would say I heard everything. I heard, the stage 4, that there's nothing they can do about it. I dealt with, the doctors that were at that lower rung that Dr. Larish talked about. I also dealt with doctors that were rungs above that who insisted that they got the endo each time. I saw who at the time was said to be the top specialist, in my area. And every time they said, we got it, there's no way it's going to come back. And they were so convinced that they removed my endo that when I was in an intense amount of pain, I was told, there's no way you still have endometriosis. You need to go see a psychiatrist, because we removed it. And it wasn't until even after I had my children and they said, oh, now you have kids, it's supposed to be better, I was still in pain. Fortunately, a few years after I had children, I did find the Center for Endometriosis Care with Dr. Sinervo, and that's where I had my last surgery, which was excision, as well as a bowel resection. I did end up needing to have a hysterectomy for the adenomyosis as well. It was also on my ovaries, my appendix, it was just about everywhere. And since that surgery, I have not had any pain associated with my endometriosis. And so that's kind of my overall journey in, in the Cliff Notes version in a few minutes. But from an infertility perspective, that's where I was first diagnosed. That's how I that's how I got the diagnosis to begin with. And in between, I've done ablations, I've done Lupron, I've done ER visits, and I've dealt with loss, and I've dealt with now ultimately I'm dealing with joy as well too. And so for me, thinking back, I wish I knew about excision all those years ago. I wish I never had to go through the grief and the financial expense that comes with so many rounds of an IVF cycle after cycle after cycle. It's why I continue to speak out about it. I tell people I'm not an expert in any of this. I'm just an expert in my story. And, it sucks. And I don't want anybody else to have to go through kind of what I went through. It is not lost on me that I have two daughters. And those of us in the community know of the link that exists from a genetic perspective. And so one of the things that I consider, even as I talk about our journey, is just the potential future impact on my two girls, and wanting to make sure that I continue to fight for them. I continue to do everything that I can to ensure that they grow up in a world where people will hear them, people will see them, people will understand them, people will treat them, people will believe them, and to make sure that if they happen to be dealing with anything close to what I was dealing with for so many years, that we're ahead of it and we address it as soon as possible, so that they have a chance at a life that is not riddled with, in my case, 24 years of pain. That's all I got.
Claudia, you're an amazing human being, and so brave and open and transparent and generous that you're sharing, your open wounds. And even though we have scars on our wounds, the scars are there and scars hurt. So I can't thank you enough. And if only you were the only person who I've ever heard that story from, unfortunately, this is what's out there. I mean, doctors telling you you have a toxic womb. You had a toxic doctor, not a toxic womb. That's number one. 7 cycles. I mean, it's unfathomable the amount of time, money, and emotional expense you've been through. And thank God you ended up with 2 daughters, and God bless them and God bless you. But there are a lot of people, trigger warning. There are a lot of people who don't end up with kids, and my heart breaks. When I see patients in the office, I'll see. I limit my office hours to 10 patients. I don't see more than 10 people in a day, because a consultation is a long conversation. It's not footnotes. You can't do the Cliff Notes version of somebody's history. It has to be an in-depth, long conversation. And I limit it to 10 patients, not only because of time, but because of the emotional toll that it takes on the doctor too. If you're going to treat people with life-altering illnesses, you have to be able to internalize what they're going through. And that's feeling other people's pain. And that's something that's part of the art of medicine that has been lost, unfortunately, upon many doctors. So, Claudia, I'm so happy that you found Ken Sinervo. He's a wonderful man and a wonderful surgeon. And I think they're not, like I said, I don't think that there are that many of us in the United States who are willing to take on the burden, emotional, the burden physical that it takes to get it done for people like you. And so I'm just so happy and you know, just incredibly in awe actually of you and your story. So thank you for sharing that with everybody.
Course, of course. And can I just say that the community is super important. And that's one of the reasons why I continue, even when things get crazy, just to make myself available to be a part of sounding board for people, just to be here, because I truly think that what I found in the endometriosis community is what helped me, even just mentally. It takes a toll on you. I have friends who, even within your home, it's not just hard on you, it's hard on, your partner as well. I've been blessed with a great husband, but it's hard for him too, to see me in pain. And so I think knowing that you have a community of not just patients and advocates, but doctors has been super awesome. I know Heather is on. I joke that, Dr. Sinerver was the first person I spoke to on the phone. Heather was the first person that I saw in person, that looked at me and said, your pain is real and you're going to be okay. And so, the community is such a big part of our story, as patients. And I just really appreciate and so grateful for doctors like you, Dr. Larish, who are making yourself available to the community as well, because that is something that it's interesting that you have so many doctors at that bottom rung who don't really know what they're doing. And they're the ones that are the first to dismiss you. And the ones that are, there are much fewer. And so there's less of you to go around for all of us, but you're the ones that are making yourself so available. And it does take an emotional toll on you as well. So thank you for being a part of the continuous community, not just with the patients that you're seeing, but with all of us as well.
Thank you. Thank you so much, Claudia, for sharing your story. We have lots of people in the chat who are saying that their heart goes out to you. They're so thankful for you sharing your story with us tonight. Do you have any parting words for our Endo warriors, our friendos in the Caribbean?
I would say your story is not over. It's hard, but you're not alone. I would say that there are times when, I just didn't want to be around anybody. And sometimes it could really just be, reaching out to say, hey, I'm struggling. Can you sit with me? And that could be enough. Your pain is valid. We see you. We hear you. We are here for you. You are not alone. There are times when I just needed to cry, and I needed to have a good long cry, and I needed somebody to not tell me not to cry, and I would do that. And then I would get myself in community, and even if I couldn't pick myself up, I would allow somebody else, I would allow others to pick me up. That's what we're here for as well, to pick you up and to help carry you when it's just too hard. And so I would say you're not alone. I would say seek community. And your story isn't over. For some, it ends one way. Different people, the endings of their story ends up being different and looking different. But I think regardless of how your story is progressing, or how it continues to progress, there are definitely people at each stage of the journey that are willing to kind of sit with you, to hold your hand, and to come alongside you in the joy and in the grief and in the suffering as well.
And Claudia, I think that was really well said. I think, as you mentioned, everybody's story is a little different. The question is, can we, as a community, by virtue of educating ourselves and others, alter and change the course for people who have not been through the trials and tribulations the way that you have? And I think the answer is yes. And kudos to you, Claudia, for being out there and putting the word out and sharing your story, because I think by sharing your story, maybe somebody out there is hearing it and saying, you know what? maybe I don't go through the 7 cycles. Maybe there's something going on here. Maybe I need to seek a higher level of care. Maybe I need to advocate for myself. I didn't realize I needed to advocate for myself. I thought the doctors were doing that for me. You know, there's a realization that happens at some point when um, they hear your story, when they hear people's story like yours, where a switch flips and you go, you know what? Nobody out there is fighting for me. I need to fight for me, and I need to demand the expertise and the level of care and the community and everything that you talked about in order for my journey not to be the same as the people before me. I mean, otherwise, what are we doing? We're just going around in circles. We need to change the dynamic course of everybody's story here in a positive way. And I think, Claudia, you're a great author for these stories,
We're gonna change it.
We're going to
Let's
change the
go.
narrative. That's great. We're going to change the narrative. In this, not just Endometriosis Awareness Month, but Endometriosis Action Month, right? For Dr. Larish, our last question, unless anyone else has any other questions, our last question is, what lifestyle changes would you say can help with endometriosis?
Well, I think lifestyle changes we need to take it with a grain of salt, right? So you're not going to treat your stage 4 endometriosis by avoiding gluten. It's not going to happen. You're not going to change your stage 4 endometriosis into the bladder by avoiding tomatoes. It's not going to happen. That's not to say that there aren't things that you can do that make you feel better. If something makes you feel better, do it. I'm the last person in the world to tell you, you tell me you avoid tomatoes and your bladder feels better, I tell you avoid tomatoes. That sounds great. Don't eat tomatoes. But to think that that's going to change, a significant disease burden is unlikely. So I think that the real lifestyle changes that can be made are to listen to your body and not to other people. Number one. Okay. Um, we think that we listen to our bodies, but we don't. We listen to a lot of the noise and drown out oftentimes what our body is telling us. And so, number one is to start listening to your body. Number two is to advocate for yourself and demand better. And I mean that demand with an emphasis on the word demand. That means demand better from the people around you who are sometimes fair weather friends who don't want to be around you when you're having pain, or if you're debilitated, or if you need assistance. It's amazing how sometimes people disappear when you're in a time of need. So demand better from the people around you, demand better from the healthcare system around you, demand better from, you just need to demand better. Number three, I think that having a community around you to support you is an incredibly important lifestyle change that one can make. And that happens in forums like this. It happens at forums like the Endometriosis Summit. It happens at endometriosis support groups across the country. Whatever it is, I'm agnostic to all these things. It doesn't matter to me which support group you go to, as long as you go to a support group, because that's where you will get strength from the people you need to get strength. It's where you will learn from other people's trials and tribulations and maybe alter your course. So to me, those are the lifestyle changes. Now, if you tell me that, eating gluten makes you feel worse, then don't eat gluten. I'm fine with that. I'll never tell you no. If you tell me, having sex in one position is better than having sex in another position, then don't. I mean, of course, do whatever feels good. That's part of listening to your body. I have no problem with that. But I think that often people times conflate superficial changes to their behavior, like the gluten and the tomatoes, with the real lifestyle modifications, which are all the other things that we talked about. And so that's my point. I'm a very long-winded person. I apologize. Maybe that's why my consultations are long. It's just me rambling.
I've got a question coming in for Claudia. What helps you through your difficult days?
So, for me, it's a couple of things. One is just being around the right people, the people that care. Not everybody cares. That really helps me. Um, I, for example, have a friend who, after we lost our sons, I was literally on the bathroom floor crying, and she came, she sat on the other side of the door, and she said nothing. She just sat there. She slipped her hand under the door, and she just sat there, right? And for me, that was the one of the best things she could have done. You know, I block out the naysayers. There are times when I just need to ignore, and it could even be in your family. Let me say that out loud. It could even be in your family, right? And so you have to know and recognize the people around you that are not adding to your state of mind, that are not adding to your peace, and find the ones that do. So that's one thing. The other thing for me is I've honestly found getting outside in the sun makes a world of difference for me. It just does. Like, there are times when I just need to get outside. I need to move. I need to take in fresh air just to really clear my head. I'm big on music. That helps me a lot as well too. Um, and there are some times where I just need to process my way through it. I am also, our whole family is a family of faith, and so for me that's a big grounding for me, whereas I just believe that at this point it's not in my hands. I have no control over it a lot of the time, and so for me, just understanding that it's bigger than me helps me to realize that I'm just not able to control every single piece of it. That also helps me to drop the shame and the guilt of my past as well. I've carried a lot of guilt around because I went through all of those surgeries, and I went through all of those cycles, and I racked up debt. And sometimes I think about, why didn't I find this sooner? Why didn't I find that sooner? I could have avoided some of these things. I could have, put my husband through less and all of these things. But sometimes I just have to tell myself, Claudia, stop it. Stop it. This was not you. You had no control over this. Take the shame off. And those are all some of the things that helped me through the difficult time as well too, because sometimes it's hard because we're also shaming ourselves, which we should not do, when what we did was, we trusted people who we thought knew better than us, when, as Dr. Larish said, we really have the power to take back the power over our own lives, over our own bodies. And thankfully now there are avenues and sources and resources for us to be able to seek out some of the treatment that we do need. And so for me, that's how I do it, is kind of recognizing that at the end of the day, no shame, no guilt. You did the best you could at the time. And when you knew better, you did better. And when the high points come, for me, I love a good sunset. And the reason why I love a good sunset, it reminds me, is that the sun rises and the sun sets. And it's dark today, but I know that as dark as it is today, and as much as the sun's going to set, it's going to rise again tomorrow. And it's not always going to be this dark, and it's not always going to be this way. And so I hold on to that as well too. And so I go through it in waves. Some days are better than others, um, you know, but yeah, I go through it in waves.
Thank you. Thank you both so much. I really appreciate everyone coming and listening to Dr. Larish and Claudia today. I really appreciate everyone who came and spent the time with us. I really appreciate Dr. Larish and Claudia for telling us your stories and helping us understand infertility a little bit better. Thank you to everyone. Thank you to Odelia, our founder of She is Lotus, Komet, and the rest of our executive board. And yes, this will be available later on Facebook. So we have the Facebook Live going, and it will be saved, and you will be able to rewatch this later or share it if you need to. And thank you, thank you, thank you. Does anyone have any final words, or Dr. Larish?
I wanted to say thank you for the opportunity and in speaking to you all. And you know, Claudia, you're an amazing person. If I wish I met you earlier in your life, maybe we could have changed your trajectory a little bit. Although you look like you've come out of this stronger, beat up but stronger. And that's
Yeah.
beat up a little bit but stronger. We all carry our scars, our medical scars, our life scars. It's just we don't want to become the scar. You want to carry the scar, but not become the scar. And maybe that's the last thing that I can say about that. Um, uh, can't thank you guys enough. Wonderful, really wonderful. Thank you for allowing me to be here.
Thank you. Thank you so much.
Thank you. Have a good night, everyone. Bye-bye.
Take care.